How is pancreatic cancer diagnosed? Hello, this evidence-based content is prepared by Sabur Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been told they need testing for pancreatic cancer, you're in the right place. I know hearing those words can be overwhelming. This is one of those diagnoses that immediately triggers fear. But today we're going to walk through exactly how pancreatic cancer is diagnosed, from the first imaging studies to definitive tissue confirmation. Before we dive into the specific tests, let's establish what we mean by diagnosis. Diagnosing pancreatic cancer isn't just about finding a mass on a scan. It's a comprehensive process that involves imaging to detect and characterize the tumor blood tests, to provide supporting information, and critically, tissue sampling, to confirm the diagnosis and guide treatment decisions. The cornerstone of pancreatic cancer diagnosis is specialized CT imaging, and this is where precision matters. When you present with symptoms like jaundice or unexplained upper abdominal pain, you'll typically undergo either a contrast-enhanced CT of the abdomen and pelvis, or if jaundice is the primary symptom, a right upper quadrant ultrasound first. But here's where it gets interesting. Even when the tumor itself is hard to see, what we call isoattenuating because it has the same density as normal pancreas, there are secondary signs that alert us. These include the double duct sign, where both the pancreatic duct and common bile duct are dilated, present in 62 to 77% of pancreatic head cancers. If you're supporting someone through this, understand that this initial imaging is the roadmap. It determines whether the cancer is resectable, removable by surgery, borderline resectable, locally advanced, or metastatic. Each category leads to fundamentally different treatment approaches. You'll likely have blood drawn for a marker called CA19-9, carbohydrate antigen 19-9. Now I need to be very clear about what this test does and doesn't do, because there's often confusion here. CA19-9 should not be used as a diagnostic test for pancreatic cancer. Let me repeat that. It's not reliable enough on its own to diagnose cancer. So why do we check it? CA19-9 has value as a prognostic marker and for monitoring disease activity in patients with initially elevated levels. If it's elevated before treatment and then normalizes with therapy, that's a good sign. If it rises during surveillance, that signals potential recurrence. This is where diagnosis becomes definitive. Endoscopic ultrasound, or EUS, with fine needle biopsy is the best modality for obtaining tissue diagnosis, even when the tumor is poorly visualized by other imaging. Here's how this works. You'll be sedated, and a specialized endoscope with an ultrasound probe at its tip is passed through your mouth into your stomach and duodenum. The power of EUS is in the tissue sampling. Using EUS guidance, a fine needle is passed through the bowel wall directly into the pancreatic mass to obtain cells for examination. Now, what about the difference between fine needle aspiration FNA and fine needle biopsy FNB? FNB is increasingly preferred because it provides core tissue samples rather than just cells. If you're supporting someone through this procedure, know that it typically requires sedation and takes 30 to 60 minutes. The main risks are pancreatitis, inflammation of the pancreas in about 1 to 2% of cases, and bleeding, though serious complications are uncommon. EUS also provides staging information. In certain situations, additional imaging may be necessary. Magnetic resonance imaging with MRI-MRCP, magnetic resonance cholangiopancreatography, offers no significant advantage over a properly performed pancreatic protocol CT for local staging. However, MRI has increased sensitivity for detecting small liver metastases compared to CORT. PET-CORT scanning using the tracer FDG has been controversial in pancreatic cancer. The sensitivity ranges from 73 to 94%, with specificity from 60 to 89%. One UK multicenter trial of 589 patients found that adding PET-CORT to standard CT improves sensitivity, specificity, and predictive values. Once adequate tissue is obtained, whether from the pancreatic primary or from a metastatic site if distant disease is present, molecular testing is increasingly important. This involves analyzing the tumor for specific genetic mutations that may make it susceptible to targeted therapies. National Comprehensive Cancer Network guidelines now recommend universal germline testing your inherited DNA, for all patients diagnosed with pancreatic cancer regardless of family history. This is because approximately 10 to 15% of pancreatic cancers are attributable to genetic causes, even in patients with apparently sporadic tumors. Here's an important exception. If you're a surgical candidate with a clearly resectable pancreatic lesion that's highly suspected of malignancy, based on imaging and clinical presentation, preoperative biopsy may not be necessary. Now, this might seem counterintuitive, but here's the reasoning. While a positive biopsy confirms cancer, a benign sample doesn't exclude malignancy. So here's your bottom line. Let's talk about the 3 categories of action you can take. Organize your medical information. Create a folder, physical or digital, containing all imaging reports, pathology reports, and blood test results. Write down your complete symptom timeline. When symptoms started, how they've progressed, and what makes them better or worse. Ask about the specific imaging protocol used. Confirm whether you've had a dedicated pancreatic protocol CT scan with multiphasic contrast enhancement or whether additional imaging is needed. Ask, does this imaging give you enough information to assess resectability? Clarify the biopsy approach. If EUS-guided biopsy is recommended, ask, will you be doing FNA or FNB? Worsening jaundice. If the whites of your eyes or your skin become increasingly yellow, this indicates progressive bile duct obstruction requiring intervention. Don't wait for your next scheduled appointment. Severe uncontrolled pain. New or worsening abdominal or back pain that isn't controlled with prescribed medications warrants immediate communication with your oncology team. Let me quickly recap. Pancreatic cancer diagnosis requires a systematic approach, starting with pancreatic protocol CT imaging, supported by CA 19-9, when appropriate, and confirmed through EUS-guided tissue biopsy that allows both diagnosis and molecular profiling. Your next step: ensure you have comprehensive imaging and a clear conversation with your physician about the biopsy approach and timeline for completing your diagnostic workup. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.